All right, complications of PCIs in general. Not talking about femstop complications, but PCIs in general. Of course, they get the hematoma from the access, and they could get pseudoaneurysms that develop because of the access points. All these little pseudoaneurysms can develop. You might not get a hematoma, but you'll get this little false lumen that develops. Sometimes that happens with like repeated sticks, like when they go to a STEMI, it's emergent, it's like 1 in the morning, right? And then they get a STEMI at 4 in the morning, they get a STEMI at 6 in the morning, they're like super tired, and like, multiple pokes can be a problem. So using ultrasound can help, okay? And of course, post-op, we can use the post-PCI, we can use Devastop to avoid hematomas forming. Limb ischemia is always a complication, whether from the sheath or from a clot from forming. And then what else? We can have retroperitoneal bleed, as we mentioned. Gets just like pancreatitis, hemorrhagic pancreatitis gets that the colon sign or the Gray Turner sign. When you turn the patient, you get a Gray Turner sign. That's just for retroperitoneal hemorrhage. So it's the same symptoms if you have a cath lab patient. You turn them over and you see that they have 4 liters of Code Red Mountain Dew inside their, inside the retroperitoneum. That can, of course, drop the hemoglobin, can drop their blood pressure, and that's something that we want to confirm. All right, and we can do that with the CT angio, can confirm that they have this hemorrhage occurring in their retroperitoneal space. So those are access site problems. What about non-access site problems? So they get what are called atheroembolisms. That's all the debris that gets freed up from the procedure, and it can go to the brain and cause a stroke, and go to the kidneys and cause some occlusion of the kidneys and acute tubular necrosis, causing damage to the kidneys, and that's why we want to trend the creatinine, give fluids to help wash out all this debris. Or again, the CIN, the contrast-induced nephropathy, yeah, sure, we can track that, but more contrast they might say, "Oh, give more fluids," but really the fluids, at least 12 hours worth of fluids is ideal. Okay, the stent itself can reocclude, right? If the patient gets discharged, they can get reocclude if they don't take their meds. So we want to make sure they know exactly what meds they need to be taking. If you have any other med you have to afford at Walmart, because we do have underserved population here. So any other medication you have to buy, you want to buy the Plavix, and you want to buy the aspirin, or the Brilinta and the aspirin. Those are the brand names, right? So CVA from debris enlargement, tamponade, when they go in there and open up and deploy that stent, they can go through the coronary artery, and that can cause a tamponade to occur on the patient. So that's something we're looking at post PCI. Is the blood pressure trending down? Why is it trending down? Are they having like a new heart attack on me, and they're going to cardiogenic shock? Are they retroperitoneal bleed, or is this a tamponade? So how would I know they have a tamponade? You got JVD. And they got a low blood pressure, and then we can do an X-ray. You might see some widened heart compared to before, but usually an echo is the best thing we can look at. You can clearly see on the echo the space of blood that's around the heart. Right? And infections can occur with the closure devices. So again, the 6 Ps we talked about, those guys are looking for paralysis, pain, a pulseless extremity, you have pallor, paresthesias, and perishingly cold, or poikilothermia, or cold extremity. These are things that tell you that they're having a blockage due to the sheath itself, or maybe worst case scenario, a debris from the clot from the heart, or from the atheroma from the heart. Okay, and here's our tamponade sides down here. All right, some meds they should be on after their cath lab, right? So meds should be they need to be on dual antiplatelet therapy if they had a stent placed, right? So what is DAPT, right? Or dual antiplatelet therapy? That is aspirin is always the baseline, so we're always on aspirin, and we're going to add something else, right? And what are we adding? What's going on there? What are we adding? We're adding a P2Y12 inhibitor. So what is P2Y12? It's just a little receptor site on top of our platelets that when it gets activated, it's going to activate that platelet. Do you want platelets activated? No, right? Because if they activate, that's going to form a thrombus, and that's going to form a clot within our artery that we don't want to happen, right? So this plaque will rupture. It could rupture in the future, right? When they do a stent, it doesn't fix their diet and exercise, or it doesn't fix their LDLs. They still have to do those things, right? So we give these things to help avoid the stent from reoccluding, and also avoiding a MI in the next year or so. And it's about from 3 months all the way to up to 18 months. They can be on this DAPT therapy. It depends on what stent they get and how risky they are, what kind of bleeding risk they have, other underlying problems they have. So again, it's up to the cardiologist. You just let them know you're going to be on these for about 3 to 12 months. Make sure you're on them. I don't want to see you again, right? So that's the idea behind DAPT therapy. It's blocking the P2Y12 inhibitors sites. So ticagrelor or Brilinta is the hot thing in the last 8 years. It's a new medication that everybody's on. Or clopidogrel, Plavix, right? It's more than 10 years old. Therefore, the patent expired at the FDA, and therefore you can have Equate brand or Kirkland brand Plavix, right? It's not called Plavix anymore. It's called clopidogrel because Plavix was marketed in the first 10 years, right? And that's how drug companies make their money by, they have the patent for 10 years and nobody else can make it, right? But then after 10 years, it elapses, and now other people can make it. Okay, so I think Brilinta is just about getting there. I think it's just about getting to 10 years. But these guys are going to stop this platelet from getting activated. And we don't want that platelet to get activated, right? Because why would the platelet activate in the first place? It sees an atheroma that ruptured, right? The atheroma ruptures, that plaque ruptures, exposes collagen. It's a rupture in the endothelium. All these things trigger the coag cascade. And the coag cascade triggers platelets, right? And platelets get triggered by the plaque rupture. And platelets, when get activated, they release enzymes and chemicals that activate the coag cascade. So it's a whole cascade of events that occur, right? So we want to stop it right at the source right here. So if we have reduced atheromas, that's great. But these are all sexy snacks for platelets and for the coag cascade to get activated. That giving DAPT therapy, dual antiplatelet therapy, because just giving aspirin is not good enough, right? Aspirin, yeah, it's great for just someone who hasn't had this intervention, and definitely after the 12 months or 18 months, they're going to be on aspirin for life, because it's going to be the piece that's going to stop platelets from activating at baseline, right? And how does aspirin work? It inhibits cyclooxygenase 1. It prevents the formation of thromboxane A2, right? So aspirin is a COX blocker. That's how it works. All right, what else? So we got P2Y12. Those are the receptors that get blocked. All right, and Plavix is irreversible, which is not great, right? Someone goes for a PCI and says, oh shoot, your left main's occluded. You need to go for open heart surgery. Well, you got to wait 7 days, right? Because Plavix is irreversible. You cannot reverse Plavix. You can give platelets, but Plavix is still in the system and it's still going to inactivate those platelets. So Plavix is not great because of that reason. Whereas ticagrelor or Brilinta, it is better than Plavix. It reduces mortality more. It has less bleeding. It has all of these great things, but it is a lot more pricey, and it's also reversible. So if they do need to get a procedure done, they can get it done. All right, we just give platelets, and that's going to help help them get the procedure they need. Okay, Prasugrel is an old medication. If you see someone on that, it's an older version before even Plavix. And then Cangrelor is the new guy on the block. So Cangrelor is the IV form of Plavix, or the IV form of ticagrelor. And that can be given like post-PCI. Like, oh, they're super risky. We keep them as IV drip, and they might go to open heart. I might take them back to cath lab. That's where they would get this IV form of the medication. Okay, and then yeah, for 3 to 12 months, depends on their bleeding risk, depends on what kind of stent they got. That's what's going to determine how long they should be on DAPT therapy. But which one should they be on for life? Aspirin, indefinitely for aspirin. Okay, what if they didn't get a stent placed? And what if they couldn't do a PCI? Sometimes they'll be on heparin afterwards. They'll come back from cath lab on heparin for 48 hours or so, for 2 days. Does it work? No. It's just to make us feel better, right? You got a heart attack, so don't get any medication? I got heparin for you, right? So it works like 10-20% of the time. It's not a great thing to do. And before cath lab, though, we might give heparin as well. We give Lovenox as the equivalent. If they can't tolerate that, sometimes we can give Fondaparinux or Fondaparinux if you're French, right? Those are different medications we could give to heparinize the patient, so that at least we prevent further clots from developing in the hospital setting. And then they have all these allergies. We can use even leech spit or bivalirudin as some other medication you might see thrown around. Okay, and inhibits these other receptor sites, these 2B3A receptors on the platelet. And in the cath lab, and sometimes for 12 hours after cath lab, they'll get these leech spit synthetically, right? Which is called these 2B3A inhibitors. They sound like someone like scatting in New Orleans and Creole. All right, they're saying epitide, and they get apixaban, and they get what else? They get tirafaban and abciximab, right? So it's like light jazz music going right now, right? So those are medications that are also can be given for high-risk PCIs and to help a patient that has like a lot of clot burden, a lot of clots, and a lot of blockages. They might be on that post-cath as well. Okay, it's like a Plavix. but we have, we get Cangalore that has better outcomes compared to the other guys. Okay, and what if a patient's bleeding? What if they're a bleeding risk, right? They come back, they're on these DAPT therapy, and they develop a GI bleed, or they develop a hemorrhage in the brain. What do you do afterwards? So that's where the bleeding patient on DAPT therapy. So what happens? You're probably going to hold it at least for 3 days. That's usually the goal. Sometimes they'll hold it indefinitely. They'll be here for like 2 weeks in, 3 weeks in. Oh, no, they have this diagnosis. We got to hold it. It's like all the recommendations say 7 days, right? We're going to hold on to it for as long as we can. We're going to hold on that P2Y12 as long as we can. But as soon as they start developing what's called a high-risk bleed, like a grade 3, grade 4 bleed, that's like an intracranial hemorrhage, a massive GI bleed, right? Like a retroperitoneal bleed, then yes, you need to let go and you need to let them get the, hold the DAPT therapy. Okay, so life-threatening bleeding, yes, that's where we're definitely going to hold it, right? But after the bleeding has been resolved, they had endoscopy for GI, they had, we monitored them in the ICU, we had the blood pressure control for a intracranial hemorrhage, then we are just going to, restart the DAPT therapy within 3 days or 7 days. Usually 7 days for neuro, 3 days for GI. Okay. In the interim, though, if they have this huge bleed, you're not going to hold on to the DAPT therapy, right? You're going to, we need to fix this. And how do you fix it? You can give platelets, but also you give the reversal agents for whatever anticoagulants they might be on. Are these for, this 4-factor prothrombic complex concentrate, PCC, or Kcentra is the brand name. That's usually our go-to agent for anybody that's on anticoagulants or antiplatelets initially. If they're on anticoagulants as well, which they might be, right? They might be on with AFib, with apixaban or Eliquis. They might have to get reversals of that. Okay, so that's the idea behind restarting the therapy, right? Basically, after 7 to 10 days, we are going to restart. But also, what about if they have a planned procedure? It wasn't like a GI bleed, unplanned GI bleed, as opposed to a planned one, right? Unplanned GI bleed or unplanned hemorrhage of the brain. What if it's a planned hip surgery or planned? They're going for abdominal surgery. Usually 7 to 10 days is how long we're holding DAPT therapy, because that is the duration of how long a platelet lasts in the body. So by 7 days, all those platelets should be fresh, and we can then do surgery at that point. Okay, so that's the idea behind how long you should wait for restarting these, or how long you should wait before going to surgery. You should hold the medications and wait this long. But again, we are going to hold on to them as long as possible. If it's going to be a surgery scheduled on Labor Day and the surgeon's out in Mexico, it's like, well, let's go ahead and plan this so that we just 5 days or 7 days based on the severity of the surgery as well. Okay. So if there's no risk, no bleeding risk, and they are kind of resolved, the GI process is resolved, their intracranial hemorrhage is resolving, then we can restart medications. We restart the DAPT therapy. This is for a patient that is no bleeding risk. I said if they are bleeding risk, 3 days, 7 days, but no bleeding risk, surgery went great. All right, we're restarting everything back up because we want them to get a heart attack in the hospital while they had like a hernia surgery. Okay, so which happened right there next door. Right, so they had hernia surgery and then they developed a heart attack and now they're in cardiogenic shock because of it. So we want to make sure that we are avoiding that and restarting anticoagulation as soon as possible. Right. So you restart DAPT therapy in 24 hours. If there's no bleeding risk, no GI bleed, no hemorrhage, great. Let's go ahead. No grade 3, grade 4 risk. Go ahead and restart therapy within 24 hours, basically. Right. Maybe 2 days, but not longer than that. Otherwise, they're at risk for getting another MI or another decompensation. All right, so chest pain. Someone has chest pain. You have a patient who had a cath lab 3 days ago, or you have a patient on the ventilator, or a patient that's like a DKA or something, and now they have, oh, I got chest pain. Or you have a patient coming in with classic chest pain. What happens, right? What do you give? Well, we don't give Mona, right? So no Momona. So that is retired, right? So in red, morphine is not given, oxygen is not given, nitrates, sure, you can do it. It's not going to reduce mortality, but it's not going to has absolutely no benefit according to the research, right? So but what does work? Aspirin. That makes sense, right? Aspirin is going to stop the platelets from aggregating. If they have a clot, it's not going to get bigger. Okay. So aspirin is the only remaining therapy we use. And we may even start a P2Y12 inhibitor while they're on their way to cath lab, right? They get a loading dose. Right, and sometimes they might be on like a heparin drip as well. If they aren't a STEMI, they're going to come to ICU and they're going to be on a heparin infusion, or they might get like a little heparin IV push before they even go to cath lab. Okay, and then if they're not going to cath lab or even post cath lab, we definitely want to be starting a statin, beta blocker, ACE inhibitor, and ARB, as long as they don't have what kind of dysfunction? Can you give an ACE inhibitor and ARB? Renal dysfunction, right? No renal dysfunction, then go ahead and throw the ACE inhibitor ARB in there. If they do have some renal dysfunction, we're going to trend it for 24 hours, 48 hours. Looks good. We can go ahead and restart these guys. Okay, so why not give morphine anymore? Well, it hides the chest pain too good, right? So the chest pain is gone, and they don't report the chest pain again, and my patient's just sleeping in the room. They're doing fine, right? They're breathing 12 breaths a minute, but they have no chest pain, and they could be having chest pain underneath. So we can't recognize that. The other thing is that morphine actually interferes with the drugs we gave them for antiplatelets. It interferes with Plavix, it interferes with Brilinta or ticagrelor, it interferes with aspirin. And do we want aspirin and ticagrelor working? Yes. So don't give morphine because that's going to interfere with those, right? And then oxygen. I thought oxygen was always good. Well, it actually causes more free radicals if your SAT's more than 94%, and those free radicals are going to impair myocardial, myocardial repair, right? I would say twice. Anyways, the O2 is going to interfere with the repairing of the heart. Your body's natural way to repair the heart. It's going to repair it up. But if you have all the oxygen there, it's going to like putting oxygen in your Jello mold. What am I thinking of? When you make things, there's like bubbles in it. It's like, oh shoot, I got to start from scratch, right? Like if you're doing like laminating, there's bubbles in there. It's kind of the same thing. You think of free radicals as bubbles, and they're going to interfere with things throughout the body. And here, it's where the patient's post-MI. You don't want them to have all these bubbles inside the tissue that's being repaired, the myocardium, right?
So this is only post?
This is pre and post. So this is someone that comes with chest pain, basically. We're kind of recapping now. So the patient comes with chest pain, and it looks like an MI, or even if it's not, you give nitrates that can tell you diagnostically if it's fixing or not, but you're not going to give that patient with chest pain morphine, right? You're not going to give that patient with chest pain oxygen unless you are desatting. I don't want to hear in an email, but Aaron told me not to give oxygen. The patient's desatting 87%. No, it's the patient that is less than 92%, you're going to give oxygen, right? The goal SAT we mentioned before for that is 92, 94%. That's where someone with an MI or stroke, that's where the SAT should be, right? Anybody else, less than 92, 80 to 92. All right, nitroglycerin, no benefit, right? And if you do give it every 5 minutes, you're going to ask them what questions? What's your blood pressure? But what else you hopefully you assess that. But what else you can ask them? How's your pain? So you can assess if it's getting better or not. What else?
Take any sexual syndrome.
Yes. So a PDE inhibitor, phosphodiesterase inhibitor, otherwise known as Viagra, right? Sildenafil, or what's the other popular one, right? Yes, Cialis and such, right? So they make sure they're not on these drugs because that's going to precipitously drop your blood pressure to a life-threatening hypotension. If they're leaving the hospital, they might be on this PO agent, ranolazine, but it's just a nitrate. All right, so that's the idea. When someone comes with ACS, we hit them up with aspirin, a P2Y12 inhibitor, an anticoagulant, and we assess do they need cath lab right now or not. If they have ST elevation, they're going to cath lab right now, right? We're doing percutaneous coronary intervention. Okay, that is the goal if someone has ST changes, right? If they don't, we might just monitor them, or they might need a CABG at some point. So we assess these things to see what the next steps are after we fix their chest pain initially. We can't just fix the chest pain and it comes back and fix the chest pain and it comes back and fix the chest pain. We have to get all the diagnostic tests rolling, right? What kind of diagnostic tests do we have to get done? You want to get echo, or you want to get a 12 lead, right? You want to get a X-ray. You want all these things to assess an troponin level, to assess if they need to go to cath lab right now or later be okay. All right, so standard therapy with someone with ACS, whether they go to cath lab or not, is to get beta blockers, right? You can give it beforehand, but usually afterwards we're giving beta blockers because what do beta blockers do? They do reduce the heart rate, as we know, and reduced heart rate is less oxygen consumption. That makes sense, right? But it is going to prevent ventricular remodeling, right? When we are repairing our heart muscle, again, we want bubbles in the way. We don't want too much oxygen, but also we don't want anything else interfering, right? We don't want people underbidding the job, right? They're going to come in like our own sympathetic nervous system will come in and say, hey, I can make those cabinets for you. Perfect, right? They're going to underbid, they're going to sit, and they're going to come back, and it's going to have really weird myocardium. It's not going to be strong, right? So giving beta blockers stops the SNS from causing ventricular remodeling or abnormal ventricular remodeling to occur. Okay, so that's the reason why we are giving beta blockers. And what else reduces ventricular remodeling is our ACE inhibitors and ARBs. They also block the SNS and angiotensin 2 from remodeling our heart abnormally. We want our heart to repair as naturally as possible, or not naturally, but as unimpaired as possible, right? When your stress response and your SNS fires off and the angiotensin 2 fires off, that's going to create an abnormal abnormal hearts, right? You can imagine if you're building things under stress, it's not going to look great, right? So that's the idea behind beta blockers. And when can you not give beta blockers? You know, they got some CHF exacerbation on your hands, right? So how do you know someone's in CHF? Well, they can have a history of CHF, but CHF exacerbation is one step higher, right? That's usually why you get admitted to a hospital or ICU for CHF exacerbation. That's someone really who's in pulmonary edema, right? Or they are in cardiogenic shock. That's someone that has, that's how you know someone is in exacerbation. And you're not going to give beta block to that patient because their heart is barely pumping as it is. You don't want to suppress it more. Okay. Also, cocaine-induced MI. They got an MI. You're like, I'm going to give beta blockers. Well, there's different varieties of beta blockers. There's beta blockers that block all the adrenergic receptors, all the SS receptors. There's ones that just block the ones in the heart, which is kind of our goal for our MI patients. If you do that with someone with cocaine, now you have, if you're just blocking the heart, everything else is unimposed, and you're going to have all this cocaine-related hypertension, and that's going to cause even more strain on the heart. So we want to make sure we give beta blockers that block everything for someone that has a cocaine overdose. Or not overdose, or cocaine use, right? And then going back to like beta-1 specific beta blockers and ones that we want to, that have the best evidence for patients with MIs and for CHF for that matter, is ones that go to the tune of MBC, right? So MBC or M as metoprolol, bisoprolol, and carvedilol. Those are the only three they should be on, right? If you see someone on propranolol or labetalol, it wasn't for their ACS or their CHF. It was for something else, right? So we're giving just one of these three medications, these three beta blockers for someone with CHF, not exacerbation, but CHF or ACS.
And then just to clarify, so if it was a cocaine-induced MI and they were on one of the MBCs, that's a question.
Yeah. So someone did come with cocaine, then you would not give you would pause before you give beta blockers. You would definitely want to ask, is this okay to give? Because there are certain beta blockers like propranolol, yes, that blocks all the alpha-1 and beta-1 and beta-2 receptors. That one would be safe compared to something that like just blocks the beta-1 receptors. Now you're just blocking that, and then now it's going to spike. Okay. So perioperative MIs, we'll give these guys. Someone goes for a cabbage, we give beta blockers to avoid AFib afterwards. So beta blockers have a lot of utility in that regard. And before you give a beta blocker, you're going to make sure that their heart rate is what? Greater than 50 at least, right? Because it's going to lower your heart rate. Someone has a block already. Someone's in a junctional rhythm. Probably not a great idea to give a beta blocker, right? And certain heart attacks will cause a bradycardia, right? Or RCA MIs, right? The right coronary artery, which feeds the SA node and AV node. If that is blocked, you're going to have a bradycardia already. So beta blocker will be contraindicated in that situation. All right, so ACE inhibitors and ARBs, we give those to prevent ventricular remodeling. That's great. All right, on discharge, if they have CKD, we'll give it to them. Okay, diabetics definitely benefit from them. And statins, we mentioned, are great for avoiding cholesterol buildup in the out discharge. But we kind of find out it's great to give within 24 hours because it'll help avoid. It has anti-inflammatory properties. So we know inflammation is kind of the linchpin to this process. Okay, and if they have pain, right, we don't give NSAIDs. Aspirin is the only exception, right? Aspirin is an NSAID, but no other NSAID should be given. So no naproxen, no colecoxib, no ibuprofen, none of those, right? And why? Because it's, again, going to impair the natural inflammatory or the natural building blocks of forming myocardial tissue. And if you give NSAIDs to these patients, it starts breaking down. It's not cardioprotective anymore. These prostaglandins are no longer protective. And yeah, prostaglandins cause pain, but also some prostaglandins are healing, right? They're going to cause vasodilation. They're going to make things good, right? So if you don't do that, it puts you at risk for myocardial rupture, right? So it's a good selling point. It's like, I need my ibuprofen. I got lower back pain. It's like, well, your heart can rupture because you just had a heart attack. So once that's fixed, we can find something else for you, or there's other strategies to control someone's pain.
You said aspirin is okay.
Aspirin is an NSAID, and it's the only NSAID you can give to someone in the post-MI. Usually we don't give NSAIDs in the ICU. It's usually not something that happens, right? Because of that reason. Someone's here for an MI, or someone's here for renal failure, and NSAIDs worsen renal failure and they worsen MIs. So usually we don't give them unless we kind of absolutely say, yep, okay, well, let's restart you on your medications. All right, so the idea here is afterwards we're giving DAPT therapy, right? You're making sure they have abs, right? So you're making sure they have DAPT, right? So if they have DAPT abs, they actually have dual antiplatelet therapy, which is what? Aspirin plus a P2Y12 inhibitor, or clopidogrel or ticagrelor are the generic names, or Plavix or Brilinta, right? So they're on those guys, P2Y12. And then they're also on ABS. They're on ACE inhibitors, beta blockers, and statins. So those are the medications they need to be on post-cath, because we know giving those things early has good outcomes. But you have to be aware of complications and reasons why we would not give it, right? So you would not give a statin post-cath if you saw what? Yeah, increased liver function, which technically is decreased liver function. But yeah, so you have your AST, ALT is elevated. That's probably, we're going to pump the brakes and say, well, maybe we should hold the statin for today. And you run it by the cardiologist or intensivist. Okay, so STEMIs are ACLS. So you learn this in ACLS. And we know if someone has a STEMI, we have up to 90 minutes to get them fixed in a cath lab, right? If you don't have a cath lab within 2 hours of you need to then get thrombolytics, right? Thrombolytics within, I think it's 60 minutes, right? Or 30 minutes, sorry. So PCI within 30 minutes, sorry. It's door to needle, 30 minutes, door to balloon, 90 minutes. That's your goal for someone for ACLS, okay? And how do you know you need thrombolytics? It's been less than 12 hours since symptoms have happened, and they don't have access to a cath lab immediately, and then we give them thrombolytics, right? And if their ST segment is not going down, they still have chest pain, well, guess what? You're getting a helicopter flight to Palmdale from Ridgecrest, right? They're going to then come over here, and we're going to activate the STEMI team, and they're going to come in and see what's going on, okay? And then we're going to be giving aspirin Plavix even pre-cath lab. They'll even load them up ahead of time. All right, and then only give oxygen if needed. Don't give nitro or morphine. They're not really going to work, and morphine is actually worse. So nitro is preferred for pain if they are not hypotensive. And we get all the workup done, all the diagnostic tests we talked about. The echo, they get a 12 lead first, probably, because that's going to let us know within 5 to 10 minutes. I think that's our goal here. When we look at ACLS, within 5 to 10 minutes, we get a 12 lead done, so we can assess, do they have ST elevation? Because if they have ST elevation, we have to, kick all the wheels in gear. Okay, and then what else? So a STEMI, if they have a STEMI, the goal is 90 minutes or 30 minutes for door to needle for thrombolytics. And if they have an NSTEMI or unstable angina, we're just going to monitor them and see if they get worse. And those are the patients that are actually at highest risk of decompensation. Okay, they can start going to AFib on you, going to VTAC. They can start getting chest pain, and you give nitro, does it go away? You give nitro, does it go away? And shit, it's like 3 a.m. Do I have to call somebody? Yeah, you do, because that's persistent refractory chest pain. What does refractory mean?
It doesn't go away.
Doesn't go with treatment, right? Like someone with increased ICP and a head bleed, they start having refractory nausea and vomiting. It's like I keep giving them nausea medication, but they keep vomiting. That's someone that needs intervention immediately. Okay. They start getting signs of heart failure. It's probably needs to be escalated. Start getting more crackles. They start getting more short of breath. You started your shift at 2 liters, and now they're on a non-breather. That's a problem. They're getting, and it's my NSTEMI patient, and they don't have pneumonia. So what's going on? Why are they getting all these CHF symptoms, for instance? All right, and then worsening EKG findings. That's where we're going to then talk about next with our STEMIs.